Our lecture today about the intra-aortic balloon troubleshooting. Regarding the intra-aortic balloon troubleshooting, we have a lot of causes of the intra-aortic balloon troubleshooting. It could be due to timing errors, due to augmentation errors, balloon pressure errors, problems related to the tachycardia, intra-aortic balloon, what should you do during the CPR, and if you have cable disconnections, arterial line malfunction, and at the end, if you have evidence of any balloon rupture, what you should do. So the first troubleshooting is related to the timing errors. The inflation error could be due to early inflation or late inflation. The deflation error could be due to early deflation or late deflation. So how to assess the timing errors, especially the inflation errors of the timing? So basically, you should spot the intra-aortic balloon with the ratio 1:2. So you will be able to assess the augmented waveform in comparison to the unaugmented waveform. So you have to put the reference line, move it to till you reach to the level of the diacritic notch here. This is the reference line. And if the inflation point is, this is the inflation point, if the inflation point is at the same level of the diacritic notch, so your inflation timing is optimum and you don't have any issue with the inflation timing. And you have to move the reference line up and down, up to compare the unassisted systolic pressure in comparison to the assisted systolic pressure. And ideally, the assisted systolic pressure, it should be lower than the unassisted systolic pressure. And if you move the reference lines down, so you will be able to compare the unassisted end-diastolic pressure in comparison to the assisted end-diastolic pressure. And ideally, the assisted end-diastolic pressure should be lower than the unassisted end-diastolic pressure. Going to the first abnormality, which is the early inflation. What is meant by early inflation? So what is meant by early inflation is that you know that this is the beginning of the systolic upstroke of the arterial limb. Then this is the systolic upstroke of the arterial limb. Then the systolic decline. Then you will go to the level here of the diacritic notch. At this point, the aortic valve will start the closure. And if the inflation happened prior to the closure of the aortic valve, this is what is called early inflation. How to know the early inflation? As we said, you have to move the reference line at the level of the diacritic notch after you move to 1:2 ratio, and compare the inflation point in relation to in comparison to the diacritic notch. And as you see here, the inflation point is at higher level than the diacritic notch, which means that the inflation happened very early while the aortic valve is still open. So if the intra-aortic balloon started the inflation while the intra-aortic valve is still open, this will lead to the blood will go back to the left ventricle, which is called the aortic regurgitation. And with aortic regurgitation, this will lead to increase of the left ventricle end-diastolic volume and left ventricle end-diastolic pressure, and it could lead to backflow to the lung, which will lead to increase the pulmonary capillary wedge pressure and might lead to pulmonary edema. And all these will lead to increase the left ventricle wall stress, and this will lead to increased myocardial oxygen consumption. And like that, the intra-aortic balloon is not helping the heart, so the early inflation is the meaning that the intra-aortic balloon is working against the heart. Instead of helping the heart, it is working against the heart. Is it clear?
Yes, it's clear.
Okay.
Yes, clear. Thank you.
Here, as you see, this is the early inflation, but here the intra-aortic balloon is working in 1:1 ratio. And as you see here, this is the inflation point. And instead of being here, the inflation point is coming very early, and this will work against the heart. The second abnormality is the late inflation. So the late inflation meaning that after closure of the aortic valve or just prior to the aortic valve closure, the inflation point should happen and the intra-aortic balloon should start the inflation and augmentation of the diastole. But if the inflation of the intra-aortic balloon happened late after the closure of the aortic valve, this is what is called the late inflation. And as you see, if you applied the reference line after moving to 1:2 ratio, so this is the level of the diacritic notch, and the inflation point should happen here, but actually the inflation point happened here. And as you notice that it happened very late, so this will lead to the suboptimal diastolic augmentation. So instead of happening here, the inflation point and the augmentation happened to reach to this point. So the inflation started at this point. With full augmentation of the intra-aortic balloon, you will reach only to this level. So what will happen with the late inflation is that the intra-aortic balloon started the inflation point after the closure of the aortic valve, and this will lead to suboptimal diastolic augmentation and also suboptimal coronary perfusion. And as you see, the characteristic waveform here is that you will notice that you will not find the sharp V shape of this notch, but you will find it wide notch here. Okay, as you see, this notch, instead of being V-shaped or sharp V-shaped, you will find the gap here is wide. So this is the characteristics of the late inflation. The late inflation, the intra-aortic balloon is not working against the heart like the early inflation, but the intra-aortic balloon performance will be suboptimal because the balloon augmentation will be suboptimal and the coronary artery perfusion will be suboptimal. And as you see here, this intra-aortic balloon performance is working into 1:1, and as you see here, the V-shaped inflation point is very wide here, and the augmentation is suboptimal. Going to the third abnormality, which is the early deflation. What is the meaning of the early deflation? The early deflation, as you know, that the intra-aortic balloon should start the inflation during the diastole, and the inflation of the intra-aortic balloon, if it is prolonged, should happen during the diastolic cycle in order to improve the augmentation and also in order to improve the coronary perfusion. But what happens if the deflation happened very early? And this will lead to the augmentation of the diastole. It will be reduced, and the coronary blood flow also will be reduced. Like that, you are not maintaining the coronary perfusion properly. And there is also one more phenomena. It happened with the early deflation. So this is the intra-aortic balloon inflating during the diastole. So the blood should go to the brain, to the cerebral circulation, and also the blood should go to the coronary while the aortic valve is closed, because this is the diastole. So with the inflation of the balloon, the blood will go to the coronary. So what will happen if the deflation happened very early and very fast? The balloon will start the deflation very early. So what will happen is that the blood, instead going to this direction, the blood will go to the other direction, which is called retrograde flow of the coronary, or what is called coronary steal phenomena, where the blood, instead of going to the coronaries in order to perfuse the heart, the blood will go back from the coronaries to the aorta during the diastole, and this will lead to coronary ischemia or angina, chest pain to the patient. So the early deflation will lead to suboptimal diastolic augmentation, suboptimal coronary perfusion, and if it happened very fast, it will lead to coronary steal phenomena or retrograde coronary blood flow, and this will lead to angina or more ischemia to the patient. And also, if you noticed, if you compared the early deflation to the other one, which is to the normal waveform, you will find that, sorry. So instead of going like this, so you will notice that the deflation happened very early, and the inflation time, this is the inflation time, so it will be augmentation time or inflation time, it will be very short, but this is the time for the balloon deflation, so it will be prolonged. So the time for the balloon inflation will be very short, and the time for the balloon deflation will be prolonged. And as you see here, this is the time for the balloon inflation, and then here this is the deflation point, and the time for the deflation is very prolonged. This is very characteristic for the early deflation. Going to the latest, the last abnormality, which is the late deflation. Late deflation means that the intra-aortic balloon was kept inflated for longer duration during the diastole and started deflation very late, while the after closure of the after opening of the aortic valve. So probably the deflation of the intra-aortic balloon, it happened during the systolic part of the cardiac cycle. So this will lead to more prolonged diastolic augmentation, which might happen during the systolic phase. This will lead to increase in the afterload, and this will lead also to increase the oxygen consumption by the heart, because the left ventricle has to contract to work against the increased afterload it was done by the prolonged inflation of the intra-aortic balloon. And as you see here, this is the inflation time. It was very prolonged, and the deflation time it was very short, which means that the deflation was happened very late. Instead of happening here, the deflation happened here at this point. So the deflation time was very short, and the inflation time was very prolonged. Prolonged inflation time, this will lead to increase the afterload against the failing heart, and this will lead to increase the oxygen demand by the heart. How to adjust the timing of the intra-aortic balloon? Basically, most of the intra-aortic balloon running through the auto mode, and in the auto mode, the operator can adjust only the time for the deflation, but the inflation timing will be automated by the machine. So in order to adjust the timing for the inflation, you have to go to the semi-auto mode, and once you go to the semi-auto mode, you can have the option to adjust the inflation and also the deflation timing. And as you see here, this is the auto mode with inflation happening automatically by the machine. But once you convert to the semi-auto mode, you will have access in order to adjust the inflation and the deflation timing by manipulating this button for the inflation timing and the deflation timing. So here, this is the normal timing for the intra-aortic balloon by the auto mode. Here, this is the auto mode. And here, as you see, the deflation time can be adjusted by the operator. And if you check the timing here, it's optimum. And here, if you compare this one to this one, you would notice that the timing here, the inflation timing came very earlier here compared to this one. So instead of inflation at this point, the inflation happened very early. And if you check the trace, you will note that this is the timing for the diacritic notch, and the inflation point happened very early here. So this is early inflation of the intra-aortic balloon. How to adjust it? Just manipulate the inflation timing, move it from this point to this point to make the inflation point at the same level of the diacritic notch. And the next abnormality is the late inflation. And as you see here, the late Sorry. As you see here, this is the point of the diacritic notch. So the inflation point should happen earlier here, but actually the inflation point, instead of happening at this point, it happened at this point. And as you see, the inflation time by the operator, it was moved forward. So this patient is having late inflation of the intra-aortic balloon. In order to adjust it, you have to move this point backward to this point in order to make the inflation point at the optimum timing. And the next abnormality is related to the deflation timing errors. And at this one, the operator moved the deflation point from here to here, and this patient is having the early deflation. And as you notice that there is and the inflation timing here is very short, but the deflation timing is very wide. And this is the time for the inflation, and this is the time for the deflation. So this patient is having early deflation and more prolonged deflation time. And the latest abnormality related to the timing is the late deflation. And as you see here, this is the beginning of the deflation, and the time for the deflation was very short compared to this one. So from this point to this point is the inflation timing, and the deflation timing is from this point to this point. So this patient is having very short deflation time and very prolonged inflation time because of late deflation. Going to the next troubleshooting, which is reduced intra-aortic balloon augmentation. And as you see, this is a patient with decreased augmentation. So the augmentation should reach to this point. Instead of reaching to this point, the augmentation actually maximum augmentation was at this level. And this patient is having decreased augmentation, and probably it is related to timing error, which is the late inflation of the intra-aortic balloon, because the inflation should happen here at this point, and the augmentation reached to this point. And because the inflation point happened at this point, so the maximum augmentation of the intra-aortic balloon, you will not reach to this point, you will reach only to this point, and this will lead to suboptimal balloon augmentation. And the causes of the intra-aortic balloon reduced augmentation, it is related to many factors: patient factors, balloon factors, catheter factors, and also timing factors. The factors related to the patient is related to the heart rate of the patient. If it is more than 120, so the tachycardia will decrease the time for the cardiac cycle, and also will decrease the time for especially the diastolic time, which is needed by the intra-aortic balloon in order to increase the augmentation during the diastole. So tachycardia with heart rate more than 120 will reduce the intra-aortic blood pressure. And also other factors can affect the augmentation of the intra-aortic balloon, like the stroke volume. If the stroke volume of the patient is very low, ml, so the augmentation of the intra-aortic balloon will be suboptimal. Additionally, if the patient is having MAB less than 40 or severe vasoplasia, this will lead to marked reduction of the diacritic notch. The level of the diacritic notch will be very low, and the inflation of the intra-aortic balloon and augmentation will be very low. And the balloon factors, it is related to the setting of the intra-aortic balloon. If you put the augmentation 100%, so you will be able to get good augmentation. If you decrease the augmentation of the intra-aortic balloon to 80, 70, 50, so this will affect the augmentation of the intra-aortic balloon. The factor related to the catheter, if you have a catheter leak, so you will have poor inflation of the intra-aortic balloon, and you will not get optimum augmentation. And also, if you have a kink, you will have poor inflation, and also you will not have the proper deflation of the intra-aortic balloon, and both will affect the augmentation of the intra-aortic balloon. The last factor, which is the timing, and as we see here, the timing can affect the augmentation. If it's late inflation, the augmentation will be suboptimal, and if it's early deflation, if it's early deflation, it will affect the augmentation because the time for the inflation time, it will be very short, and the augmentation of the intra-aortic balloon will be suboptimal. Going to the next abnormality, which is the balloon pressure waveform errors. And this is a normal graph for the balloon pressure waveform. So you will have the inflation point here, then the inflation limb, and you will reach to the peak here, which is inflation overshooting. After that, the pressure inside the aorta and pressure inside the intra-aortic balloon will be equalized. This will lead to appearance of the plateau of the intra-aortic balloon. And at the end of the plateau, you will reach to the deflation point, and the deflation point will be followed by the deflation limb, which will end with the deflation overshooting. Then the pressure will be equalized again. So you will go back to the filling pressure baseline, which is most of the cases at the level of 10 to 15 millimeter mercury. So you might have abnormality related to the filling pressure baseline. It could be above the normal level, or it could be below the normal level. You might have disappearance of the plateau pressure, and you will get this waveform without getting the plateau. Or you might have the plateau, or it could be suboptimal. So these are the abnormalities related to the balloon pressure waveform. So the first abnormality is that you have a low intra-aortic balloon filling pressure baseline. And as you see here, it should be at this point, at this level 10 to 15 millimeter mercury, but actually it is low here and going down. So it could be due to balloon rupture or disconnection of the helium pipe. The next abnormality is that the filling pressure baseline is above the normal, or above the default baseline, which is 10 to 15 millimeter mercury, and this could be due to balloon malfunctioning or manufacturing errors. So the pressure inside the intra-aortic balloon, it will be over pressurized, or it could be related to a kink of the intra-aortic balloon, and the kink might lead to improper emptying of the intra-aortic balloon. So the pressure inside the system will be higher than the normal level, and the balloon filling pressure baseline, it will be elevated, as you see here. The next abnormality is that if you have the plateau pressure suboptimal, or the plateau pressure below the normal level, it could be due to multiple causes. It could be due to too small balloon for the patient. It could be due to severe hypotension. It could be due to vasoplegia, low stroke volume, or it could be due to the balloon position. It could be too low or too high, and all this will affect also the balloon pressure. So the blood pressure, the systemic vascular resistance, the balloon size, the balloon level, stroke volume, all will affect the plateau pressure level. So it might be very low if all this reduced, or it might be very high or absent of the plateau because of the opposite. And as you see here, there is loss of the plateau. Instead of having the inflation overshooting, then the plateau like this. So the plateau disappeared, and you will have only this waveform. It could be due to the intra-aortic balloon is too big for the patient. It could be the patient is incredibly hypertensive, and the balloon could be positioned too high in the aorta, and the catheter could be kinked. And this is an example of the catheter kink. Of the kink, it's the intra-aortic balloon catheter. You will notice that you will lose the plateau of the intra-aortic balloon pressure waveform. As you see here, this is the plateau of the intra-aortic balloon, and this is the inflation overshooting, deflation overshooting, and this is the plateau. So once you kink the catheter, you will start to lose the plateau, reaching to this one. And as you see, this is the waveform with the catheter kink. Going to the next troubleshooting, which is the intra-aortic balloon rupture. So if you have ruptured intra-aortic balloon, you will find blood either in the tube of the intra-aortic balloon, the helium tube, or inside the balloon itself once you remove it. So what is the evidence of balloon rupture? It will be suggested by blood in the helium tubing, and the intra-aortic balloon will not work. It will go to the standby, and suddenly the patient will have hemodynamic instability, and you will find the alarm in the console. The action should be taken. You have to support your patient, ABCD. You have to optimize the hemodynamics for the patient, standby the intra-aortic balloon, clamp the helium line in order to prevent the gas embolism, and either to remove the intra-aortic balloon or to change the intra-aortic balloon based on the clinical situation for the patient. The next abnormality is if you have an arterial line malfunction, like this one. Actually, the arterial line is not working, but the intra-aortic balloon is kept working because the intra-aortic balloon is operating through the auto mode. So the balloon is relying on the ECG as a trigger for inflation and deflation. But if the intra-aortic balloon is shifted to the semi-auto mode and you change the trigger to the pressure, so the intra-aortic balloon will not work in this situation. So if the arterial line is not working, it could be due to the port for the fiber optic probe is not working. And as you see, this is the port for the fiber optic. And the new catheter, there are two ports for arterial line measurement, either through the fiber optic or through the conventional arterial line, which is connected to the bag with Hepson line in order to maintain the patency. In this situation of the fiber optic not working, then you can connect this one to arterial transducer, and you can connect the arterial transducer to the port for the arterial line, which is the external port, not the direct one. So this is the direct source for the arterial pressure monitoring by the intra-aortic balloon, and this is the external source for the arterial pressure monitoring in a situation of emergency like malfunctioning of the fiber optic. So when you work on the fiber optic, you have to select the source to the direct mode. If you change it to the external source, then you have to change the direct source to the external source by the intra-aortic balloon. Otherwise, you will not get the trace for the arterial pressure. The intra-aortic balloon during the CPR. So it has been published by many publications that the intra-aortic balloon is able to improve the outcome of the CPR, because when you start the chest compression, so the blood will go from the heart to the aorta, and the intra-aortic balloon will start the deflation. This will improve the forward flow of the blood. And once you release the chest compression, so with the recoil of the heart, so this with the compression of the heart, the blood will go to the aorta, and the intra-aortic balloon will start the deflation. And when you remove the chest compression, the aortic valve will start closure, and the intra-aortic balloon will start the inflation. This will lead to perfusion of the cerebral circulation and also perfusion of the coronaries. And this has been proven that the intra-aortic balloon during the CPR, it will decrease the time for the ROSC, and also it will improve the outcome of the cardiac arrest. So what you should do during the CPR in order to make the intra-aortic balloon work properly. If your intra-aortic balloon in the auto mode, you have to convert to the semi-auto mode and change the trigger to the pressure trigger. And when you do the CPR, this will make pressure wave form inside the aorta. And once you change the trigger to the pressure trigger, the intra-aortic balloon will follow the arterial pressure waveform and start inflation and deflation according to the arterial waveform. But if the console does not recognize the arterial pressure, it might be due to the low quality of the CPR. So in order to correct this, you have to apply high quality CPR, chest compression, in order to get adequate form of the arterial waveform. But despite that, if it's not working, so you have to put the intra-aortic balloon in the standby mode, but not for longer duration in order to avoid the balloon thrombosis. And also one of the recommendation during the intra-aortic balloon during the CPR is that to set the augmentation down to 50% during the CPR. I'm not sure about the exact cause for this recommendation, but this was the recommendation by many publications. Defibrillation during the intra-aortic balloon, you can do the defibrillation during the run of the intra-aortic balloon, but you should you should be clear of the intra-aortic balloon in order to avoid any electrical activity. The most common abnormality or the most common troubleshooting you will face during the intra-aortic balloon is the tachycardia. And as we know, the intra-aortic balloon performance is relying on many factors. One of these factors is the heart rate, balloon position, volume, stroke volume, MAB, systemic vascular resistance, and the balloon diameter and occlusivity. And the most important one, which is the heart rate and the rhythm. So what will happen if you have tachycardia? So with tachycardia, you will get a shorter time for the cardiac cycle. So this is a normal patient with normal heart rate. This is the timing for the cardiac cycle. And this is the timing for the cardiac cycle if you have tachycardia. So you will have a short time for balloon inflation. And this patient is not tachycardic. So the balloon inflation and augmentation here will be maximized. But here, the balloon inflation and augmentation will be very short, and the patient will not benefit properly from the intra-aortic balloon. So with tachycardia, you will have shorter cardiac cycle, you will have shorter diastolic time, and you will have shorter diastolic augmentation. And as we know from the physiology behind the intra-aortic balloon is that the area under curve of the diastolic perfusion time index is a surrogate of the coronary perfusion. So the area under curve it will be reduced, and the coronary perfusion also will be reduced. And with the tachycardia, the myocardial oxygen demand it will be increased, and with the reduced coronary perfusion, the oxygen supply to the heart it will be also reduced. And as you see, comparing this patient with heart rate of 82 to another patient with heart rate of 130, you will find the augmentation here reached up to 114. With tachycardia, the augmentation has been reduced to 97, and the hemodynamics also compromised. This is the systolic pressure, diastolic pressure, systolic pressure, diastolic pressure, and this is the MAB. So the hemodynamics will be compromised with the tachycardia. The augmentation of the intra-aortic balloon will be reduced with the tachycardia. And if you have a VTAC, so this is a normal sinus rhythm, and suddenly the patient developed VTAC. So as you see, the augmentation has been reduced markedly, and the hemodynamics will be also compromised. And as you see, the timing for the intra-aortic balloon inflation will be very short, so the balloon will not work properly. And if you have AF, so if you have AF, so the balloon inflation and balloon augmentation will be variable. Sometimes it will be okay, sometimes it will be very short, very shorter, then go back. So the patient will have fluctuation of the blood pressure, fluctuation of the augmented pressure, and this will lead to improper performance of the intra-aortic balloon. So the effectiveness of the intra-aortic balloon will be reduced with tachycardia, probably if more than 120, and also the rhythm also can affect the performance of the cardiac intra-aortic balloon performance. So the arrhythmia, tachycardia, all is not beneficial for the patient with cardiogenic shock when on intra-aortic balloon. So you should consider to reduce the inotropes in order to decrease the tachycardia. You should consider cardioversion, and also if the patient is awake, it might increase the tachycardia, so you can increase the sedation for that patient. And as you see, this is the physiology behind the coronary perfusion of the patient with intra-aortic balloon. So this is the diacritic notch. So this is the systolic pressure time index, diastolic pressure time index. And the time for the diastolic pressure time index is a surrogate for the coronary perfusion. This is the coronary blood flow during the diastole. So if you increase the heart rate, so the timing for the diastolic pressure time index will be short, and the time for the coronary perfusion will be reduced. So this will decrease the oxygen supply to the heart. Going to the next section, which is the complication of the intra-aortic balloon. So the complication of the intra-aortic balloon, it might happen due to vascular complication like the limb ischemia, amputation, systemic embolization like cholesterol or helium embolization. It might happen due to bleeding at the site of the insertion. And the other vascular complication, it might lead to thrombocytopenia. It might lead to stroke if there is a systemic embolization due to atheromatoous plaque. The mechanical complication, it might be due to the balloon rupture, balloon leak, balloon displacement, balloon, it might be entrapped, you cannot be remove the intra-aortic balloon, inadequate diastolic augmentation, inadequate inflation, clot formation in the pressure line, and distortion of the pressure line. And the life-threatening complication is the aortic dissection, aortic rupture, and also infection, sepsis, and septic shock. You want to continue with more? This is the last section of the intra-aortic balloon, the weaning.
Yeah, sure. Please continue.
How
Going
many
to the
slides,
next,
doctor? How many slides?
I think maybe 10 slides, maybe not that
That's
much.
okay.
Okay, so the weaning of
10:30.
the the weaning of the intra-aortic balloon. To start weaning of the intra-aortic balloon, you should have the criteria for weaning. So the criteria for weaning is that you improve the cardiac output for the patient. The cardiac output for the patient has been improved. The patient hemodynamic stability was achieved, and the patient is not on high hemodynamic support like vasopressors and inotropes. And the weaning mode, there are many weaning modes. So either to wean the assist ratio, meaning meaning that you have to move from 1 to 1, then 1 to 2, then 1 to 3, and this is the most common approach. And the other approach is to wean the assist augmentation, meaning that if you are starting with augmentation 100%, then gradually decrease the augmentation to 90, 80, then 70%. Once you achieve 70% augmentation and the patient hemodynamics maintained, so you can proceed for intra-aortic balloon removal. So in order to start the weaning with the common approach, which is the assist ratio weaning, so you have first to ensure the weaning readiness and change the ratio 1 into 2, then assess the patient for up to 60 minutes. If the patient is not having tachycardia, hypotension, arrhythmia, or is not having hypoxemia or any signs of pulmonary edema, then you can, if the patient is stable, you can go to the ratio 1 into 3, then wait for another 1 hour. If the patient hemodynamics is okay, clinical parameters are okay, then you can proceed for the intra-aortic balloon removal. And the second method, which is weaning the augmentation ratio. So you can decrease the augmentation by 10% for 1 hour, then assess the hemodynamics for the patient, then again decrease 10%. So once you reach Once you reach to 70%, so you can go for the intra-aortic balloon removal. And removal of the intra-aortic balloon, prior the removal, you have to stop the hyperinfusion for 3 hours, and you have to make sure that the APTT is less than 50 in order to reduce the risk of the bleeding. During this period, the balloon the weaning protocol for the intra-aortic balloon should be conducted, and if the patient is stable, you can proceed for removal of the intra-aortic balloon. So the patient should be positioned flat, and the catheter should be removed, after which the pressure will be applied above the femoral area for up to 40 minutes in order to stop the bleeding. Once the bleeding has been stopped, so you can remove the pressure and apply sandbag and assess the perfusion of the limb frequently in order to avoid any limb ischemia. Thank you. Any questions? Hello?
Thank you, doctor.
Thank you, Akas.
Thank you, doctor.
Thank you.
Doctor, I have a question. Can we use
Okay.
during a CPR IABP on an internal mode?
This one of the use of the internal mode. This one of the use of the internal mode is to use it if the patient is having asystole. So we can set the rate up to 80, but usually
Yes,
the internal mode they are using during the bypass.
yes, bypass line.
But using the internal mode during the CPR, because the
Mhm.
recommendation for the CPR is to do chest compression between 100 to 120 per minute. Okay,
Yes,
so
yes,
if you are doing chest compression 100 to 120 per minute and you are keeping
mm,
the internal mode fixed, okay,
yes,
so if you put the internal mode fixed at 80, that means the intra-aortic balloon will inflate 80 only.
mhm,
So you
yes.
will not find the synchrony between the chest compression and the inflation and deflation of the intra-aortic balloon.
Okay.
So the chest compression, it might happen and the blood will be displaced from the heart to the aorta while the intra-aortic balloon is inflated. So it will work in opposite direction. So it will not help the patient. So I think
Mm,
the internal mode should not be used in the CPR, but it should be
okay.
used in the bypass only. The most reliable one is to move to the trigger of the pressure trigger.
Pressure. And then reduce the augmentation up to 50%.
Yeah. I don't know exactly why they want to decrease the augmentation to 50, but this I read in many articles.
Okay.
Yeah, Dr. Masri, I have a question.
Okay.
And yes, I want to add one more thing. First of all, you talk about the CPR, whether you should use IABP with the CPR or not. Mostly cardiologists say, and some studies I have read about, they say it's not recommended to use IABP with the CPR because you are applying the external compressions, and as well as IABP is also putting compressions, from the inside of the heart. So in this situation, the IABP won't be effective. But if you have to use it, you can do one thing. One study showed that you have to, as you already told about the trigger, that if you set the trigger to the arterial waveform, then it can
Yes.
synchronize well with the pressure waveform and can
Yeah.
ILVP work along with the CPR compressions.
Yeah.
Vice versa, it will manage it.
This
And
what
in
I
this
said in the
situation,
lecture. Mhm.
yeah.
Okay.
And along with that, you have to take one precaution that you have to set 50% augmentation. The reason you will set 50% augmentation is you're working 50-50. 50%
Okay.
chest compression, 50% IEBP. So this is the
Yeah.
safer way one can go only. Otherwise,
Yeah.
it's not recommended to use the IEBP with the CPR.
Hmm. Yes. Yes.
Yes, and my question is actually, you mentioned in the reduced IABP augmentation slide, and it was the fourth point. It was vasoplegia. I want to know about this. Can you tell me more about this?
Okay.
Yeah.
I will just get some graph.
Yeah. It was a slide reduced IABP augmentation.
Yeah.
Yeah.
Um,
IABP, reduced IABP augmentation.
okay. So this is the arterial waveform. Okay. This is the normal
Yeah.
one. And this is the critic notch. And this is the inflation of the intra-aortic balloon. And this is the augmented pressure peak, right?
Yes.
Okay. So what will happen if you have a vasoplegia? What will happen if you
Yeah.
have vasoplegia? So you will have the diastolic blood pressure here. It will be low. It will go to this point. And the diacritic notch, it will be also very low. So it will go to this point. Okay.
Hmm.
Okay. So the
Yeah.
inflation point, instead of happening at this point, it will happen lower here. Okay. Right.
Hmm. Yes.
So the inflation, the augmentation of the interval 100%, it will move the pressure from this point to this point. But if you started from this point, you will not get this point, right? You will get the
Right.
point maximum here. Because with
Okay.
vasoplegia, all the pressures going down, so the inflation point, it will be very low, and you will not achieve the maximum augmentation because the inflation point started not from here, it started from here because the map and the diacritic notch, it is low if the patient is vasoplegia. You
Okay.
got it? You got it?
Yeah, I got it according to the waveform. But you know what? It will happen. Like I want to
Mm-hmm.
know about this situation, vasoplegia itself.
Uh-huh.
Vasoplegia. What the situation will be like for the body? Is that a kind of a what I can say? Like I want to know this terminology
Okay.
actually, vasoplegia.
Vasoplegia. So vasoplegia is so you have this what is the mean of vasoplegia? You have the artery, okay? The artery is like a circle, okay?
Yes.
So the artery is having the characteristic is that it can be it can be distendable and it will have also the ability for elastic recoil, okay?
Yes.
And the width of the artery, it can be controlled by other factors like vasodilators or hormonal. It can control what is called the vasomotor tone. Okay, so if you have a sepsis, like infection in the blood, so it will release the toxins, and these toxins, it will cause vasodilatation. Okay, so so the circle of the artery, instead of being like this, so the artery will be vasodilated. Okay, so the width of the artery, it will be increased. Okay, so what will happen if you increase the width of the artery or the width of the aorta? You will start the inflation of the intra-aortic balloon. Okay, so and the pressure inside the aorta is very low because the aorta is too much dilated because of vasoplegia. You got it?
Uh, Balloon is inside the aorta. So are you trying to
Okay.
say that there will
I am
be
telling
some
the occlusivity. Okay. So this is the aorta. Okay. This is the aorta. Let's say this is the aorta. This is normal diameter for the aorta. Okay.
mm,
So if you have vasoplegia, what will happen? The diameter of the aorta, let's say aorta or any artery, the diameter, it will be increased. Okay.
increase?
Because the vasomotor tone, it will be reduced. So you will have the state of vasoplegia. It will cause more dilatation. Okay. So
Okay.
the intra-aortic balloon will achieve the maximum inflation, but actually the aorta is dilated because of sepsis. So this will lead to reduced augmentation because as we said, the intra-aortic balloon should occlude the lumen of the aorta 80 to 90%. But with vasoplegia, you will not be able to occlude the aorta 90 to 80%. So this will decrease the augmentation of the intra-aortic balloon. Okay?
Okay.
This is one reason. The other reason is that the inflation point at the level of the diacritic notch, it will be lower. So the inflation point, instead of happening here, it will happen here. okay, and the maximum inflation of the intra-aortic balloon will be the same. So you will not be able to reach to this point because the maximum of the intra-aortic balloon to increase to this point only.
Okay.
Okay.
So sepsis and increased dilatation will lead us for this condition, which is vasoplegia, right?
Yeah, vasoplegia, it will make the balloon occlusivity will be suboptimal, and also the inflation point of the intra-aortic balloon because the aortic notch will be lower than the normal, so the inflation point will be low. And if you saw the that one for the late inflation. Actually, what happened in the late inflation is the same happened during the sepsis, right? So the
Hmm.
inflation should happen here. So you will get the peak to this point. But if the inflation happened here, you will get the peak at this point only. Okay?
Okay.
So what happened in the vasoplegia is that the diacritic notch moved from this point to this point. Okay? And the inflation, instead of happening at this level, it happened at this level. So you will not be able to reach to this point. Okay, so two reasons,
So
because the balloon occlusivity is suboptimal and also the inflation point, it happened at a lower
inflation
level.
point is low. Yes.
Yes.
And in this condition, the vessel will dilate furthermore because it is decreasing the augmentation, right?
Sorry, again.
Yes. This condition of vasoplegia will increase the dilatation of the vessel furthermore,
Okay, yes,
and it will reduce the augmentation as well.
yes.
The more furthermore dilatation is just because the augmentation is reduced.
Sorry, again.
In this vasoplegia condition, we said
Hmm.
the vessel will dilate further,
Yes, yes,
more than
yes,
its ability and extent.
yes.
So the reason, of course, we discuss its sepsis, dilatation, increase in dilatation, of course. I just want to ask whether it will dilate further than this point, like how I can explain you. It's of course it's because of sepsis and dilatation.
Mm-hmm.
Augmentation is also playing a part in this. It's like a defect from coming from our intra-aortic balloon pump, or it is forcing the balloon to decrease the augmentation.
No, no, it's not related to the balloon. It's related to the patient factor. As you see,
Patient
there is,
factor,
yes, this is patient factor.
patient factor.
If you remember that slide,
That the
this
vessel
one.
is increasing
Yeah,
the dilatation further.
you remember this
Yeah,
slide
this
that
was the
reduced the
one, first
augmentation?
one.
It's some
Yeah,
patient
this
related
was
to
the
a
one.
factor related to the patient. One of them is
Yes.
the vasoplegia and stroke volume. The factor related to the balloon, either you set the augmentation low, or there
No,
is a
okay.
kink or leak or timing issues. This is related to the machine and the balloon, but this is related to the
Okay.
patient itself because he's having
Itself.
severe vasoplegia. So
Okay.
the balloon is working properly, but the patient
Hmm.
circulation is too much dilated and the pressure is too much low. So with a maximum balloon performance, you will not be able to achieve the optimum
Hmm.
augmentation pressure you want to the patient. This because of
Okay,
the
I got it.
patient, not the intra-aortic balloon.
Okay, okay, I got it. But on the intra-aortic balloon pump, it will be showing a sign in a way, late inflation or early deflation. By which you will
Hmm.
be getting to know it's vasoplegia or something like that
Yes,
happens to
yes,
the
yes,
patient. Thank you so
yes.
much.
Yeah. Any further questions?
Doctor, how do we know that this is a factor of vasoplegia or this is a factor of a time related to IABP?
As you know that the timing, to assess the timing, we said to shift it to 1:1. And if the timing, inflation timing is okay, that means it's not related to the timing factor.
Okay.
And if you check the deflation, if you have early deflation, it will affect this one. So if you are able to diagnose late inflation or early deflation, so
Mhm.
you will be able to know this is related to the timing factor or not. Sometimes it's combined. Sometimes the patient is having vasoplegia and is having also timing errors. So, but if timing error, you can fix vasoplegia, you can add vasopressors, you can add steroids, you can give some volume for the patient to improve the systemic vascular resistance for the patient. And you can add other medication like vasopressin, methylene blue in order to treat the vasoplegia. So you have to know what is the issue. Many patients you will find mix due to timing factors, due to patient factors. So you have to treat.
So if patient is vasoplegic,
Vasoplegia,
uh,
the
then
vasoplegia you
should we
can,
start the vasopressor?
yes, yes. If he's having vasoplegia, if he's having low MAP, diastolic pressure less than 40, MAP less than 40, so you have to start MAP less than 60, you have to start vasopressors. Okay.
Okay.
And to know vasoplegia or not, you can check this one, the intra-aortic, the pulmonary artery catheter, and it will give you the measurement of the systemic vascular resistance. If it's low, that means the patient is having vasoplegia. Or you can put another heme-monitoring device like BECO, or which is called pulse indexed cardiac output monitoring. It will give you also the measurement of the systemic vascular resistance.
SPF.
Yeah.
Yeah, Dr. Masri, I have one more question.
Okay.
Yeah, the question is, weaning the patient by augmentation or by ratio, which way is better and safe for the patient? Because I have read many articles and there are different studies. Some say like augmentation, some say ratio. I want to ask from you what you say.
Actually, the most common one, they are weaning the ratio. Okay. But the
Okay,
more physiological one is to wean the augmentation percentage.
okay,
But the
okay.
common approach, I told you, the common approach is to wean the ratio 1:1, 1:2, 1:3. This is not any the more beneficial to the patient. The more beneficial to the patient is to wean the augmentation percentage uh, 10%, then assess the hemodynamics another 10%. Once you reach to 70%, so it's more physiologic to the patient. And also, you are not exposed to the risk of balloon thrombosis, much like the you put the balloon into 1 into 3 for longer duration.
Hmm. Yeah, because I saw one, two hospitals, they were also weaning by augmentation, but maybe
Yeah,
because of the precautions they have to go for, like they cannot reduce lesser than 60 and they have to, go for a certain level of augmentation. They have to take care. That's why maybe most of the people are not preferring to wean off by the augmentation. So
and
yes, according to
some
you, its
hospital,
ratio is a safe. Some hospitals,
yeah,
yeah, I have
some
seen.
hospitals they are doing both together. They are
Yeah,
decreasing
both
the
together.
augmentation.
And I have,
Yeah.
yeah, and I
Mm.
have seen reducing by augmentation first, and then later on they go for ratio reduction.
Yeah, yes, yes.
Yeah,
They are doing some hospital doing
yeah,
this, some protocol doing this.
yeah, they are doing.
Um, I was about to tell something, but I missed
Yes,
it. I forgot it. Hmm.
okay. So my next question is probably
I
seen
also
in,
I have seen
yeah.
many new consoles, the ratio reaching up to 1:8. I saw this console in Farwanaya Hospital. Have you seen this console
Yes,
with
this is a
one? Yeah,
Teleflex IABP data.
I didn't work with this one. I saw it only once.
Yeah, there is one recent one as well. Yes,
Mm,
that offers very least ratio that you can go for.
yeah.
Of course, there will be the same concept weaning by the ratio or weaning by the augmentation. So, in short, we can conclude that weaning by ratio is preferable if
Mhm.
as it's safe and easy, but weaning by augmentation won't be easy if you are not expert, isn't it?
Yeah, yeah. But
And
anyway,
you cannot.
Anyway, the idea is to wean whatever the method of weaning and to monitor the patient for the hemodynamics, the
Hemodynamics.
oxygenation, the lung water index. There are many parameters clinically. It will give you the impression the patient is okay or not. So if the patient is tolerating the weaning, whatever the method, so you can carry on. But which one is the best? And what I know from the articles is the augmentation percentage weaning is much more physiologic because it will take longer duration and it will not affect the hemodynamics like the weaning from 1 to 1 into 1 into 2. This is very fast, right?
Yes, yes, yes.
Yeah,
This is the
and
reason.
and this might expose the heart because the heart is for in some patients the coronary perfusion in some patients relying on the assist ratio 1 into 1. You are perfusing the coronary most of the time, but in 1 into 1 there is one cycle not assisted. So during this cycle the coronary perfusion may be suboptimal. So the patient might have deterioration because of the ratio weaning. So augmentation weaning, this I think is more physiological, and this will achieve gradual weaning without harming the patient, like ratio weaning.
Yeah, true. And yes, my question is coronary seal phenomena. Can you just tell me a little bit more about this? Coronary seal
Okay,
phenomena.
yeah,
Yeah,
coronary
there was one
steal
slide.
phenomena. So this is a intra-aortic balloon. When inflate during the diastole, the aortic valve is closed, right? So
Okay.
the balloon will inflate and displace the blood towards the cerebral circulation and also will displace the blood to the coronary. Okay, this is what we know. So
Yes.
if the inflation of the intra-aortic balloon is happening and the deflation should occur, let's say after 1 second. Okay, this is a normal. Let's say this is a normal. The deflation point should happen after 1 or 2 seconds. Let's say 2 seconds. Okay. So if the deflation point started very early after 1 second, what will happen? What will happen is that the augmentation will be suboptimal. The coronary perfusion will be, instead of happening to 2 seconds, it's happening only for 1 second, right? So this will
Yes.
lead to suboptimal coronary perfusion. Okay, this is what's happening with early deflation. But if the early deflation is happened very fast, okay, if the early deflation happened very fast, so what will happen? The pressure inside the aorta will drop, okay,
Yes.
very fast, okay, will
Mm.
drop very fast. This drop, very fast drop, will cause what? Retrograde flow. The coronary, the blood flow should go to the coronaries in this direction, but with this rapid reduction of the pressure of the deflation very fast. So the blood will be go to the opposite direction because here the blood pressure is very low. The pressure is very low. So the blood will move from this point to this point. This is what is called retrograde coronary flow. So the blood from the circulation, the cerebral circulation will go back to the aorta, and the blood from the coronary circulation will go back to the aorta because of very fast and very rapid deflation of the intra-aortic balloon. And in some patient, this retrograde flow, it will lead to what is called angina for the patient because the coronary blood flow is reduced. So this will cause more ischemia to the patient. And this is what is called coronary steal phenomena.
Okay. So retrograde flow is actually this phenomena, coronary steal phenomena, right?
Yeah, coronary steal phenomena is the retrograde flow
Okay. Thank you
because
so much.
the intra-aortic balloon deflation happened very fast. This will
Mm.
create drop of the pressure inside the aorta, and this will lead to
Mm.
retrograde flow. And the retrograde
Retrograde.
flow will lead to coronary ischemia for the patient.
Mm.
And it might lead to deterioration of the hemodynamics for the patient.
Hemodynamics. Okay.
Hmm.
Thank you so much.
Okay, thank you. Any further questions?
Vakar, I think, has raised the hand. Maybe he has a question.
I don't see because because I am showing the slides because I don't see this one. Where is he? You can open the mic. Wakar. Hello? Wakar? Hello? Wakar?
Yes, yes. Wait, I will.
Mhm.
सवाल लगा जो Vakar will use my ID to ask question.
Okay.
Hi, Dr. Masri.
Hi, Wakar.
This was a nice presentation.
Thank you.
And I was asking question regarding early inflation and late deflation, but fortunately I got answers from previous discussion.
Okay.
Uh,
So, what's the question?
so my question was regarding early inflation and late deflation.
Okay.
So, what are the most common side effects of these inflations and deflations? So, what
the
we can,
early inflation.
how we can manipulate the situation if we have early inflation and late deflation? So, there is
it's
a role of balloon position in this.
I'm not sure there is a relation of the balloon position or not, but it will affect the balloon position. It will affect the this one, the augmentation more.
Yes.
The timing will be normal. Okay, it could be normal, but the augmentation, it might be affected for sure.
Yeah, of course.
The position. But if you have early inflation, it's a timing issue. So you have to adjust the inflation point and to make it at the same level of the diacritic notch. Like that, the intra-aortic balloon inflation, it will happen during the diastole. It will not happen during the systole. So it will help the heart instead of working against the heart. Because what happened during the early inflation is that the balloon is inflating during the systole. Okay?
Yeah.
Before closure of the aortic valve. So the balloon is inflating against the heart. So it's working against the heart. It's not helping the heart. Okay? It's causing more stress on the heart. Like that, the heart will not recover. So you have to adjust the inflation point to the at the same level of the diacritic notch by manipulating the inflation time buttons.
But I think there is some role regarding the balloon position also, because most of the time we see there is not good balloon trace and we are unable to even adjust the timings and adjust the balloon
But
waveform.
it will affect the augmentation for sure.
Yeah, definitely. It's affecting the augmentation as well as the patient.
But it will not affect the timing. Because the timing will happen, maybe the timing will be okay. Okay, so the balloon, if the balloon position is affected, so the augmentation might be suboptimal. Okay, you agree for this, right?
Yeah.
But it doesn't mean that the augmentation is happening in the systole, because the early inflation means that the inflation of the ventricular balloon is happening during the systole. It works against the heart. But if you have improper position, this will lead to suboptimal balloon augmentation. Okay, and this happened during the diastole, not during the diastole. So suboptimal augmentation is a thing, but the different thing is that you are doing augmentation and the balloon inflation in the systole. It's a different story. This is working against the heart, and the other one is suboptimal augmentation. You can adjust the position, okay? So you will get the proper augmentation, okay? But if you the position problem, it's not related to the timing.
Okay. Thank you.
Welcome, thank you. And what was the question regarding the late deflation?
Yeah, it's all about timings of the balloon, either early
Yeah,
or
yeah.
late.
Mm, mm. Yes, okay.
It's all about the timings. If there
Yes,
is
okay.
early or late inflation or deflation,
Mm,
your heart might be stressed, and
mhm.
your
Uh,
heart might be stressed.
yes, for sure. I think early inflation and late deflation, the balloon is working against the heart.
Yeah, yeah.
But late inflation and early deflation, the balloon is not achieving the optimum augmentation. This is my impression,
Sorry.
right?
Yes, doctor. And I think when we are checking the reference line by making IABP on a 1 to ratio, we always look late inflation, early deflation, right?
Mm-hmm. Mm, yes.
Okay.
But also you should move the reference line up and down to check the pressures, compare the assisted pressure to the unassisted pressures also,
Okay. Yes.
because yeah, yeah, okay. Because this pressure also, it might be affected if you have timing issues.
Yes, you are right. And then we
Yeah,
should move inflation or deflation according to that
yeah,
reference line.
yes, yes. Anyway, I'm suggesting that, you know, this ECMO competencies that we are doing,
Yes.
ECMO competency, why we are not doing the same for the intra-aortic balloon? We can do
Yes,
this
that is a good question. And
IABP competency, so we can do for all ICU doctors and perfusionists, and we can involve the nurses also. We can teach them.
yeah,
Why we cannot do this, yeah?
yes, we should do a competency about IABP also,
Mm,
especially the troubleshooting.
yes. I did some videos with the simulation. Ananta, he got the simulation. One day he got it, I think, the last week. And I took some
Yes.
videos for the most of this troubleshooting videos, not only photos. So we can arrange
Yes.
for something to teach the doctors, to teach the nurses regarding this troubleshooting also. So they can be
Yes.
competent. We can do this competency maybe every 2, 3 months for them. Same that we are doing for the ECMO.
Yes. Yes. I
Yes,
think we
Dr.
should
Masih,
follow
it's a
this
great
one and we
idea.
should do this.
Sorry?
Yes, Dr. Masih, it's a great idea, and even I feel sometimes it happens to the doctors while they're inserting the IABP. There are certain little steps they are missing in a way by
Hmm.
which they are not able to put that IABP successfully. And sometimes are get faced, and sometimes such kind of incidents happens. And yes, we have to go through all of this from
Yeah.
insertion till the console troubleshooting. It should be there. Yes. It will be a
Yes.
great
Yes.
revision session for all of us. Yes, great.
Yeah.
And yes, my last question is like, tell me if there is a balloon rupture,
Hmm.
how worse it could be for the patient. To what extent it could damage, and how far it could damage, could bring the damage to the patient.
Damage to what? What you mean damage?
Patient, if there is a balloon rupture, because recently some company guys came to us and they were also giving some kind of warnings and all, but it wasn't so much from the clinical point of view because we are dealing with the company only. Clamping the helium line and other factors, safety factors are always there. We try to do that. But if there is a balloon rupture, what could be the damage other than the aorta will be bursted altogether?
So it
But
will
there
be
will be
like
little factors as well.
yeah,
Yeah, little
the
factors.
They choose the helium because it's very light gas, and
Yeah, I heard.
also it can be absorbed very fast, and the damage from the gas embolism it will be very less. So the gas embolism it might lead to ischemia, okay, because
Hmm.
there will be air column inside the artery, and the blood flow will not be maintained to the organs. So it might lead to ischemia. If it went to the heart, it might lead to arrhythmia, turbulence of the blood flow. It might lead to arrhythmia also. So if it went to the brain, it might lead to stroke.
Yeah.
Okay. So the patient might get harm, but the harm from the helium it's less than other gases. That's why they choose helium because it's light gas, so the inflation and the deflation will happen very fast, and also because it's a very light gas and the body can absorb it very fast. So the harm from the gas embolism it might be very um, less compared to other gases.
Okay. So the more damage will be coming because of this external pump that will be left there when the balloon is ruptured.
Yeah, exactly. The more damage due to hemodynamic instability. And I think
Hmm.
if there is evidence of balloon rupture, I think the intra-aortic balloon, there is a safety setting, it will go to the standby mode, right?
Yeah,
Yes, and
Yeah, so
exactly.
it will
Some
not
company
yeah,
flush.
guys,
It will not
yeah, the
inflate
say
or
company
this is
guys
deflate
came.
the IABP because IABP
Yeah,
ruptured.
yes.
yeah,
So the
there
balloon
is the
will
same
stop
thing.
and you just need to clamp that one and remove it immediately. So this is what you
Yes.
can do. But the problem, once you stop the balloon, the patient hemodynamics might deteriorate if the patient is still dependent on the intra-aortic balloon. So the priority is to optimize the hemodynamics and to commence vasopressors and tropes according to the clinical situation. And if the patient is not stable, so you can only remove the intra-aortic balloon and you can introduce a new one.
Hmm. Okay.
Regarding the
Okay,
removal,
thank you so much.
I have a question regarding the removal of the intra-aortic balloon. I
Yes.
don't know, you are not supposed to do this, I know, but should be done by the physician only. But Uh, the correct method is to remove the intra-aortic balloon with the sheath both together, or we can remove the intra-aortic balloon without removing the sheath.
Yeah, there are two ways I have also seen. Some people leave the sheath over there and they just remove the
Mm.
intra-aortic balloon pump. They feel like if they will leave the sheath there, they can reinsert it. But personally, I will say leaving the sheath there won't be beneficial because um, once you leave the sheath over there, there are certain chances that that will be in a way there are chances of coagulation. And other than that, when you will put another balloon, it's preferable to prick again. Just because of saving the chances of multiple pricks, maybe they are leaving the sheath over there, but I don't think so. It's a very safe practice.
Mhm. Because
So as
from
a
my experience,
physician, you must have some other aspects from your clinical side, but from the professional side, on the personal basis, I don't feel like it's a very safe practice to leave the sheath
yeah,
over there and just removing that
because
intra-aortic balloon pump.
most of this from our point of view, because most of these patients they are getting heparin infusion, aspirin, Plavix, some patient getting agrostat, so the risk or chance of bleeding is high. And
Yes.
if you remove the intra-aortic balloon because some incident or accidental rupture, something like this, and your patient is not ready to remove the intra-aortic balloon, so I think it's more wise to keep the sheath and remove the intra-aortic balloon and introduce a new balloon through the old sheath. This would be more practical instead of getting a new puncture. It might be complicated by hematoma,
Yeah, for
bleeding.
the emergency situation, it
Yeah.
will be very
Hmm.
beneficial. Yeah, and if you're sure
But
about it, that you have to
But if
insert
it's
again.
yeah, but if you are in non-urgency situation, it's like elective
Hmm.
balloon removal. The patient stable,
Okay.
not depending on the balloon, so you can
Hmm.
remove both together.
Yeah. Yeah, both together. And
Mm.
leaving the sheath over there for longer time won't be beneficial for sterilization and all. It will be ultimately leading to the sepsis
Mm.
and all, I think.
Yes, yes. Yeah, correct.
Yeah. So thank you so much, Dr. Masri, for your lecture. It was very
Thank
informative,
you.
and thank you so much for your time. As last week you were not able to give us the time, so we are very thankful, and I really enjoyed my time during this lecture, and it was
Thank
very
you.
informative. And I will let the other people to compliment you the same way and show their
Thank you.
gratitude to you. So thank you so much from my
Thanks.
side. Thank you.
Thank you so much. Thank you. Thank you.
Thank you, doctor, for your time.
Thank you. Thank you. Have a good day. Bye bye.
Thank you.
Thank you so much. Good day.